This case, I saw this female 2 weeks ago. She is 28 years old, and her body weight 250 kilos. Never seen that fat a woman. Very, very nice, smiling young lady. Her mother was with her. She was also a little overweight, but you wouldn't look at her on the street, but you would look at her here. Height 169, BMI 87.5. And ESS, Epworth Sleepiness Scale 14 out of 21 because she can't sit and she can't drive for many, many years. That's not because of she cannot sit there. So it's not. She had no driver license. Had been fat since 80 years old. She had 2 sisters and 1 brother. They are greatly overweight, all of them. It's a genetic thing, the mother told me. Maybe what they eat, I don't know. Her boyfriend claimed, she has a boyfriend, snoring and stop of breathing in this patient during the night. Nocturia 3 to 4 times per night. And wakes several times due to difficulty to breathing during the night. But she sleeps 7 to 8 hours. And then during the afternoon, she sleeps 3 hours at least, maybe more. And she can only sleep supine on her back. She's not possible to sleep on left or right side. She can only sleep supine. So yeah, but smiling, charming young lady. Okay, let's see here. What we do so. She also suffered from rheumatoid arthritis. You couldn't see it. And she was on prednisolone, not very good for the weight. It increased appetite. Methotrexate, tramadol, it's a mild morphine, salazoparine, and ibuprofen, and pantoprazole because of gastritis and reflux, maybe due to ibuprofen and prednisolone, or maybe due to overweight. I don't know. But that was her medication. Okay, and she was referred to our hospital. She was in hospital, and we did a PSG overnight with transcutaneous CO2 and EEG and full polysomnography. We had a puncture here during the evening when we started the transcutaneous CO2 measurement 7.43, PCO2 5.7, below 6. It's not elevated, and PO2 9.9, maybe a little low, but it's not. And oxygen saturation 94 in the lower limit, and bicarbonate standard 26.6, not elevated. Normal routine blood test with the normal values, and Rheuma factor was increased. And her lung function, FEV1, 69% of predicted, FVC, 73% of predicted, a moderate or slight decrease, restrictive due to the overweight, I believe. But nothing here special. If he suffered from obesity hypoventilation syndrome, I would have expected a standard bicarbonate of 28 or 29 or 30 or higher. And also I would expected a lower PO2 and a higher PCO2. But we didn't find that. We take this apuncture because when we put on the transcutaneous CO2, it will take about 20 to 30 minutes before there is equilibrium. So it measures the right CO2 transcutaneous. And after that time, we take apuncture because you know, when you measure CO2 here, you also measure the CO2 which is produced in the tissue below the sensor. And there is always produced CO2 in every cell because of the metabolism. So CO2, when we do transcutaneous, the values might be 6 to 8% higher than the arterial values. So we have to correct these values, of course. Sometimes it's 10%, sometimes it's similar. It depends. And of course, you had to place your monitor or the sensor in the right place. Not if there's some scarring or if there's a lot of hair, or if there's a lot of blood vessels, it's not good. Intercostal places here, spaces is good here. You can use your ear lips, special, it's also okay. But you have to place in the right, else, if you look at simultaneous CO2 in the venous or arterial blood, these changes here will have a delay of 60, 90 seconds or so. It doesn't matter here because it's not acute patient. If it's intensive care unit, of course, you have intubated patients and you have index-expired to CO2 where you can measure immediate changes, not here. You have a delay 1 to 2 minutes. But it doesn't matter here, of course, because it's not acute patient. Okay, here you have our PSG from one night. You see here, that is N1, N2, N3, and REM sleep. And she had 11% N1, 62% N2, and 10% N3, and then 70% REM. A little low N3 sleep. I would have more than 20, at least 25%. So she had, there's not that amount of real deep sleep, which I would have expected here. She fall asleep after 28 minutes, which is normal. You know, there's a normal material for PSG with 4,000 Swedish females. I don't know if they're normal, but they had made a material here, and their sleep latency is about 20 minutes up to 45 minutes. So that's within normal. And if you look here at the total AITE, it was 40 per hour. And if you see 1 obstructive, 0.1 mixed, no central apnea, and 39 hypopnea. So she had ASI 40, where almost all was hypopnea, obstructive hypopnea, as shown here. You see her leg movement index was 1.4 and PLM. So there was nothing there. Leg movement more than 20, 25 per hour is abnormal, but this is quite normal. So what we found here, she had sleep apnea, obstructive sleep apnea, mainly hypopnea, and she has a decreased deep sleep, N3. Let's see here, that's total sleep time, 7 hours, and she was 8.49 minutes in the bed, so the sleep efficiency was 79%. It's okay, I believe, more or less. And you see here, number of awakeness 48 and arousals 148. It's a little too high. I would expect that she should have 10 per hour. So when you say 70 would be normal here. If you are 70-year-old, you have 15 to 20 arousals per hour. So this might be normal if you are 70 years, but not for this 28 years old. So she has a double the arousal that expected in normal material, I believe. Okay. Let's see here. That is the duration. It's Danish, sorry. And she had mostly hypopnea. The mean duration 16 seconds and maximum duration 67 seconds. You can see that. And the few obstructive apnea 37 seconds and the maximum. And if you look at sleep apnea, usually the obstructive apnea is a little shorter than the hypopnea. Usually, but the duration would be 20 to 30 seconds in most patients I see at least. And hypopnea, it will be 20 seconds to 40 seconds as a mean. And here, 1 minute and 1 to 2 minutes. The longest duration of an obstructive apnea I had seen during the last 2 or 3 years was 3 minutes. That was a long duration, 3 minutes. Yeah. So yeah. But we have got this out from the PSG, and you see here that is a hypnogram. You can see here 22 and 2 o'clock and 6 o'clock, and I think she sleep already here, some awakening here, and then she had REM sleep here, yeah, some awakening here at 20 minutes, yeah. That was a hypnogram. It's 2 o'clock, so she sleeps in fact a lot, also during the afternoon. You see here, when they come in the department at 2 o'clock here in the afternoon, we put on the equipment and we start monitoring. So often we get a lot of information here during the afternoon. A lot will sleep here, and she had a lot of sleep here, in fact, before going to sleep. Yeah. What about the transcutaneous CO2? The maximum was 6.6 kilopascal. The mean was 5.8 kilopascal. And the percentage of sleep time where transcutaneous CO2 was over 45 millimeter or 6 kilopascal, 15%, but no time more than 6.7 kilopascal. So there was an increase here from 5.8 to 6.6, or 44 to 40. So it isn't a sign of a hypoventilation. Normally, we would like to have a 10 millimeter increase in CO2 to if it's significant for more than 10 minutes, and also we would like this to be more than 55 millimeter, a sign as hyperventilation. So there's no sign of hyperventilation here, in fact. Of course, this is the results here, but we looked through the whole night and looked if there was a period with lower, but there wasn't. So there was no sign here from this transcutaneous CO2 that she suffered from hypoventilation syndrome. You see here a desaturation index 95. Usually the desaturation index is lower than the AIHE, at least in our patients, but here it was doubled. I don't know why. Low saturation, 60, very low. And usually a pulse oximeter, when it comes down below 70, it's not very accurate in measuring. So we had to be very carefully. So I'm not quite sure that's right. So yeah. But here we get out how long time the oxygen saturation is below certain levels here. And you can see here that below 90 or 90% all this time, the oxygen saturation is below 90%. And in fact, in 12 minutes, it's between 60 and 70%, half an hour, 70, 80, and almost 1 hour between 80 and 85, and almost 2 hours between here. So she has a severe desaturation during the night, in fact. So we said this is obstructive sleep apnea in a severe fat female with severe sleepiness, and we started CPAP. And then we considered a new PSG with CPAP after 3 months in hospital with transcutaneous CO2 to control. Is that right, what we found the first time? Is she also suffering from hypoventilation or what? And then we referred her to gastric sleeve operation, of course. I know they're not very eager to operate if you're on steroid. And she had to be tapered out of steroid before she can be operated. So they will try to, and that's the rheumatologist who had to do that, of course, to get her out of steroids, and maybe ibuprofen that I like, but that might be a relative simple. And then I think it's she didn't suffer from hypertension, she didn't suffer from increased cholesterol, she didn't suffer from diabetes 2 or any other disorders, only severe sleep apnea and severe overweight. And that in Denmark, at least, if you have a BIM above 35 and suffer from sleep apnea, that is an indication for gastric bypass operation. if you have no comorbidities, you have to have higher than 40 BRM. She had, was 85. So that was our decision. And then the questions. What about therapy of obesity hypoventilation syndrome? If it had been that, should we start with CPAP or NIV? And why is patients with OHS, why are they so tired? And many hypercapnic COD patients are not tired. I don't know why. Maybe you can answer that. And this, if you suffer from OHI, is an indication for gastric bypass in all of them, even if the BMI is only more than 30 or 35. At least there is for sleep apnea, but I would expect that obesity hyperventilation syndrome also should be an indication, and I think that they would accept that. I don't know. Yeah. But I was surprised that she didn't suffer from obesity hyperventilation syndrome. But she was very fresh and smiling and full of energy in the consultation room. So usually when I've seen patients with obesity hyperventilation syndrome, they almost fell asleep in my office. I don't know. Yes. Open for questions. Have you seen patients waiting that much? Yes. Yeah. I've never seen that. Yeah.
When we first started in Stockholm operating these patients, we had quite a few very, very large patients.
Yeah.
Now we kind of operate them down.
Yeah.
We have increased indications for operating
Yeah.
and also for comorbidities, so
Yeah.
they are generally BMI 35, 40.
Yeah.
But not all operations post-operatively run smooth. There's complications. There is some patients actually die, and there is quite a few of these patients that actually are using food as a drug. They are addicted to food. And when they cannot do that anymore, they will go into alcohol or pills. And if they go into opioids, then you have a bigger problem with their sleep apnea and other things. So it's not totally uncomplicated.
No?
Maybe we're over-operating at this point.
Usually when they are referred to surgery, they would like them to lose about 8% of their weight. And I thought, why? And they told me that that is because of the liver. There's a lot of fat in the liver, and they like that to be reduced before operation. I don't know if that's right, but they told me at least. Yeah.
And also that they should show if they can go down.
Complying with some diet. Yeah. 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 Yeah.
Would treating her with NIV be completely wrong?
I don't know, but it's more costly, and when I saw her all the examination, there was no sign of hypoventilation. So, but I of course it will be nice to see in 3 months if she then will develop, but I don't believe so. But what about you, Michael?
Yeah, I've never seen such a patient, but in this case, I would have started with a high pressure CPAP, maybe high level of lower, for instance, 8 or 10 to 20. But we discuss a lot of what is the right thing to do. But I have the same opinion as you. When she has a normal CO2 nightly and daytime, you can try it. But I don't know what's the best.
No.
It's worrying hypoxia, isn't it?
What?
She's really hypoxic.
Yeah. But
Is the
it
CPAP
should
gonna
go
treat
for CPAP, I believe.
I think it would because of the atelectasis in the lower part of the lung that she has will expand and improve the oxygenation. At least it's a try. It's worth to try it.
I would put her on an IV. Yeah.
Why?
Because the degree of OHS.
She has
hypopneas.
Okay.
Yeah, the hypopneas.
Yes.
Oh,
and,
yes. Just.
Yes. Excuse me. She has hypopneas, and no, I have no picture of her, but if the stomach is
Yeah.
very big.
Yeah. It's relatively large.
Yes. So I don't.
Yeah.
I think she can have a low EPAP.
Yeah. But yeah, it's gonna be next year. Maybe we can
Yeah.
present the result if there'll be a.
I just think with that degree of hypopneas, there's no apneas to treat with the CPAP. So I think when you get pure OHS, and this is what Paddy and Nick have said at the Lane Fox, is when you've got pure OHS that you even if they're hypercapnic, you should still treat them with ventilation rather than CPAP.
But this is not
Could-
an
could you
OHI.
just- Could you just show us the numbers again?
Yep. Here, 40 hypopneas per hour, and that was 39 of the 40, and then 1 obstructive per hour.
And the nightly CO2.
Yeah,
It's amazing she's not hypercapnic, isn't it?
here. Yeah. Mean 5.8 and the maximum 6.6. A little, but it was not more than 55, and that's the usual cutoff, and you would like it to increase 10 millimeter if it not was increased, but it's below 45, which is normal. So yeah, I'm not quite sure, but yeah, but in fact, if I could decide, I would have her in hospital and titrate the CPAP, but it's not possible in our hospital, so they will not like that. So, but I would do that in this case. It's so complicated, and maybe do a split night titration and set the minimum pressure to maybe 8 or 10. In 1992, when I started with sleep apnea, there was no auto CPAP. I would start her on 10 centimeter as average pressure. Yeah, but nowadays, I think she got 4 and 20. So we'll see what happens. So yeah. But I know some of you have them lying in a bed during the day, a few hours. You start CPAP and you look at them, and then you titrate already and increase the minimum pressure already when you start, and maybe that's clever. Because even if they have some apnea, sometimes the pressure is not increased. I don't know why. The algorithm is not so sensitive already, always, in my opinion. Okay.
I try sometimes when I can't bring them on the bed, that they try to snoring awake with the CPAP.
Yeah.
And when they not snore, can't snore more, then I set this this pressure. Yes.
That's clever.
And it's often okay.
That's just the definition of Pickwick syndrome, or hyperventilation during day and night. Daytime PO2 below 9.3, and daytime CO2 more than 45, and BMI more than 30 kilo, and absence of other causes of day hyperventilation, COPD, or no muscular disorders. You see here this fat boy here, fat guy, eating a burger from McDonald's. Yeah, okay, good, thank you.
Great. Okay. So this young gentleman was a 40-year-old male who'd had recurrent admissions to one of our local district general hospitals with type 2 respiratory failure. So he'd had 3 admissions in the last 5 months, and he was on home oxygen. He had a diagnosis of COPD, although he'd been a never smoker. So maybe a bit of a misdiagnosis there. He'd had a sleep study which had diagnosed obstructive sleep apnea, but he wasn't on any treatment for it. And he has arthrogyroposis, which had given him a kyphoscoliosis. So that's a long bone disease. It's a genetic condition. He was a little bit overweight with a BMI of 42. So as I said, he's been a never smoker, but still has this COPD diagnosis. lives with his mum and dad, and works in an office. So these recurrent admissions to hospital were having quite a big impact on his life because he kept having to take time off sick, and his workplace weren't all that happy with all the sickness he'd been having. So he was referred to my service for consideration of home NIV. He had daytime hypercapnia and was really symptomatic with that. So a lot of excessive daytime sleepiness, morning headaches, exceedingly breathless. So he was commenced on home NIV on the AVAPS AE mode as an inpatient via our outreach service. And during his assessment, this was what we'd found. So you can see from his chest X-ray up there that he doesn't have a lot of functioning lung. He did have a pneumonia that he was being treated for at this time as well. You can see quite how hypercapnic he was. And it had taken 3 admissions before the physicians considered that maybe home NIV might be appropriate for this young man. You can see from his spirometry he's got severe restrictive spirometry from his chest wall deformity. And you can see from his sleep study, he does have some confirmed obstructive sleep apnea, but it's only moderate. So this assumption that he'd had COPD and this assumption it was all OSA, actually it was completely his chest wall deformity that was driving his recurrent admissions and recurrent pneumonias. And I think our chest wall patients are maybe something that people see less of. And so the concept and the idea of home NIV for them doesn't always spring to mind. And I think there was a bit of preconception and a little bit of misdiagnosis going on with this chap. So as I was explaining earlier, I bring all my patients back for 6-week reviews. And you can see from the breakdown here, he was getting quite a lot of night to night, time to time variability in his IPAP and huge variabilities in his EPAP. And this was an example of one particular night where he's getting, even when his mask is fitting okay, he's still getting huge changes and swings in his IPAP and huge changes and swings in his EPAP. Just a little bit of mask leak here, but generally overnight, pretty good at less than 60 litres a minute is what we aim for. So given his results, we decided to leave him on the AVAPS AE mode because he was getting huge in-night and night-to-night variability in his pressures. At 6 weeks, his physiologically was starting to correct, so much improved on his hypercapnia. This is quite early on, and some of these long-term hypercapnic patients can take, Michael Dre, who's talking tomorrow, has shown it can take up to 3 months to get resolution in their hypercapnia. And he'd had several hospital admissions, and so we needed to give him a bit of time to recover from those pneumonias as well. And he's just been in to see us 2 years later. And I had a little chat with him. So he's really good with his NIV. He wears it. He's 100% compliant. Has the odd night off when he's had a night out on the town. I can always tell when he's had a big night. Wears it for 7.5 hours. Because of his long bone disease, he's quite short. So he's averaging tidal volumes of about 500 mils. But actually, he's shorter than me, so that will be adequate for him. He's getting minimal mask leak, despite the fact he's needing really quite high pressures at times to overcome his chest wall compliance problems. And he was so excited the day I could tell him that we could take his oxygen away. Massively. It just changed his life. So he, being quite a young chap, he found a lot of social stigma around his oxygen use. And he hadn't been especially compliant with it. He wouldn't take it to work with him because he didn't like people to see him as an ill person with a disease. And it has taken probably about 18 months of ventilation for us to get to a point where we've physiologically corrected some of his compensatory mechanisms, but we have been able to remove his LTOD. He's had no hospital admissions in the last 2 years. So he'd gone from having really quite a lot of hospital admissions quite close together to no hospital admissions. He's been able to return to work full time, and he's able to travel, although he does struggle in those hypoxic conditions. So he does require oxygen to fly, and much to his disgust, he gets quite hypercapnic on the oxygen, and so he has to have his NIV to compensate for his oxygen need. So it does mean he has to take his ventilator on the plane with him, and he has to use his ventilator on the plane, but that does mean he still gets to fly. And this was his blood gas just this week, actually, so completely corrected hypercapnia, and his oxygen levels are acceptable. So I suppose the points I wanted to highlight was around how do we educate people that aren't working in the sleep and vent field about identifying patients that might need NIV. We're seeing more and more, particularly of the obesity patients, where they're admitted to hospital with respiratory failure purely because of their obesity. So how do we educate other people that we're working with? And also wanted to highlight how the AVAPS AE has worked for this patient, how we decided to keep him on that therapy. And finally, I think oxygen, particularly for flying with, is really quite a challenge logistically for us as clinicians, for our patients, and whether people have thoughts on how we can facilitate some of that air travel with the oxygen therapy. Any thoughts, questions?
I'm always wondering if you can use an oxygen extracting device on an airplane, because with bottles there's always a problem. Okay, we can supply the patient with bottles going out, but then they land in America. There is a completely different standard of tubing and threading and etc. And then you have to have oxygen return. Maybe someone from Phillips or somebody can tell me if there's an extract that would work on the plane.
I believe it would work even if the oxygen pressure is lower, then the output maybe will be a little lower, but still I would believe it will work if the captain will allow them to use it, and that might be a question, I don't know. But there is small portable oxygen concentrators which could be used in that case, I believe. So that might be possible. Yeah.
It's a real logistical challenge, isn't it? Because the airlines are so variable on what they will and won't allow. And as Phillips says, we don't really know what percentages of oxygen we'll then be delivering with those concentrators.
We had a little boy who flies to Thailand with the Simply Go, and it was okay. But they should have ordered seats with the electric connections because the batteries wasn't good enough. So.
Okay.
We're sending out, thank you, information to all airlines right now. The big ones Air France, but also now in the Nordic level, we have made a list of all the small ones we have in all our countries. So they received a letter now on, so they can give to the patient, so they can prove that it's allowed to bring it along. So, and if you want to have that letter in your department, it's not a problem at all to send it to you, and so you have it as well. So you can inform your patients if that would be good for you.
They have to speak with the airlines also before the flight.
Yeah, but then they exactly. But then they know at least that the airplane has been, or the airline have been informed. And I have got a list from my colleagues on all the different kind of small and big airlines we have in the Nordic countries. There's a lot of them, but they will get them these letters.
I tried to send an extra battery to Thailand because it's not enough, but I couldn't do that.
You couldn't,
Phillips
no?
here in Sweden couldn't do that either, because you have to have it together with the concentrator.
Oh, it has to. Oh,
it's lithium-ion batteries. So
okay.
To send lots of battery with it.
Exactly. Yeah.
From the beginning.
Yeah, when they take off. Yeah. Okay. Yeah. But speak to my colleagues in each of your countries, and they have these approval letters, and you can get them, of course. No
Stephanie,
problem.
could you go back to the chest X-ray with the lung function? Yes, and that's a typical kyphoscoliosis. It's very difficult to look at the lung fields because she had turned the thorax and so on, and then they have this metal in the back thoracal spine for operations, I believe, because he was kyphoscoliosis. But yeah, and then if you look at the lung function, very severe restrictive reduced lung function in the male 40 years old, never smoker. He had never suffered from COPD. He doesn't suffer from COPD. It's a classical restrictive reduced lung function, and that's why he is respiratory failure. So he had never suffered from COPD. I don't know why his own doctor had given him that diagnosis. Maybe because of
It's a puzzle.
Yeah, that's puzzle. Yeah, so it's the wrong diagnosis. Yeah, also. Yeah.
I just had one comment about the oxygen in traveling, because in Norway you have the gas company who provides the patients with to help them when they order a flight. So they manage to provide them with the oxygen they need, because some travel area like the Philippines or it's not so easy. So
yeah, so in the UK, the oxygen company has the contract with the Department of Health, and the patients are not allowed to take any of their oxygen equipment outside of the UK. So if they want to go on holiday within the UK, that's fine. If they want to fly, they have to arrange it all privately.
Yeah, but they in Norway the gas companies helps.
Okay.
So but with the spirometry, 70% of predicted. This patient, how do the cough? How do we manage? I was just thinking maybe he needed a cough assist. Maybe he got pneumonia by.
Yeah, he doesn't have any. He's not had any pneumonia since he's been ventilated, and what I usually find with the chest wall patients is once you've ventilated them and opened things up as much as can be, they sometimes get a bit productive and a cough during that initial phase. Once their lungs are adequately ventilated, or as best as you can manage, then they don't tend to get pneumonias after that.